A very good morning to all of you at Ludhiana at this Yuva Congress of Foxy. It's indeed my pleasure to be addressing all of you. I am apologizing for not being present physically for this talk. I was there yesterday for the workshop. But let me take you through prenatal screening tests, what, when, and why. And I bring you greetings from the city of Agra and from our institute, Ujala Cygnus Rainbow Hospital, Agra, and our team, Dr. Niharika, Jaideep, and Keshav. So let's see what we can do. Now, first of all, we have to decide whether this problem of chromosomal anomaly is big enough to do a screening test for everyone, or should we do it only for genetic disorders? Well, the answer is yes and no. In India, the more problematic disease is PIH, 15%, while chromosomal anomalies are just 1 or 2%. So you have to balance, because it's a test, screening test, which will identify highest pregnancy. You have to balance whether we should be doing that or this or both. So PIH and medical disorders are more common and should be screened more often. And of course, but you cannot deny any woman for not screening for genetic disorders, because you still have 2 to 5% live births having congenital malformation, 13.6 in stillbirths, and 7 to 10% in neonatal deaths. So it is a big problem, out of which 0.5 are Down syndrome, single gene disorders 0.6. So all of us will see one Down syndrome baby in 800, and one Edward in 10,000, and one Patau syndrome in another 10,000. So that is the problem. Now, when we look at all the chromosomal anomalies, 60% of them are trisomy 21, 16% are trisomy 18, and 6% are trisomy 13, and then gonadal gonosomes like Klinefelter, Turner's, X and Y, and then the other chromosomal aberration. So is only Down syndrome screening enough, which a lot of people ask me, or should we do it for all? Well, you should do it for all, because the others, you will miss the others. Otherwise, there are some companies which are offering only 21 testing. I don't think that is a valid thing. Then let's come to the pyramid of prenatal care. The pyramid of prenatal care was like this in the 1930s, where every test was done at week 40, last week. Then Professor Kypros Nicolaides from 2013 inverted the pyramid of care, and it was the 11 to 13 weeks, which was the one where the maximum tests are done. And at this, you required a fetal medicine specialist, which is also called as the first trimester triage. And then the obstetrician would care for the whole pregnancy till 41 weeks. Now, on this pyramid of care, a penthouse is added. It's like a building for non-communicable disease management. And this has to be done by you and me, who are the maternal medicine specialists. And then after delivery, again, to prevent non-communicable diseases, you have to do a pregnancy-induced complication management of these patients. Again, by you and me. Only for this 11 to 13 weeks, we need a fetal medicine specialist. And it is better that we get trained ourselves as fetal medicine specialists, so we can do a good NT-NB scan and a good color Doppler in a 3D. Now let us see. In pregnancy, we need to screen for aneuploidies, that is chromosomal anomalies. We need to scan for anomalies, that is structural anomalies. We need to screen women who will undergo preterm birth and women who will suffer from preeclampsia. So these are the 4 pregnancy areas to be screened. How do we do it? Aneuploidies can be done in first and second trimester both, by ultrasound, by maternal biochemistry, and by cell-free DNA or NIPS. Anomalies by ultrasound, first and second trimester. Preeclampsia by first trimester history, mean arterial pressure, uterine artery Doppler, biochemical tests like PIGF, PLGF, and S-FLIT. And in the second trimester by uterine artery Doppler. Cervical length in the second trimester by transvaginal ultrasound, measuring the cervical length and shortening. But some studies are saying that when you do an NT scan at 12 weeks or 11 to 13 weeks, measure the cervical length then only. So if it is short there, maybe you can predict preterm birth much earlier. Now look at this. This is a pregnancy of 10 weeks. That's the placenta, that's the amniotic sac, that's the umbilical watch, and watch this picture carefully. So these are where your markers come from. From the developing placenta, we get the human chorionic gonadotrophin or HCG, beta HCG. you get inhibin, you get PAPE, you get PIGF or PLGF, and you get S-FLIT. So if there is a faulty placenta, improper implantation, or something wrong in the chromosome, which is not letting the placenta form well, you will get abnormal mom values of HCG, inhibin, PAPE, PIGF, and S-FLIT. So you will diagnose all the chromosomal anomalies, plus you will be able to predict PIH. Then alpha-fetoprotein comes from fetal liver. Now, if it is chromosome 13, 18, 21, and open neural tube defects, alpha-fetoprotein mom levels will be abnormal. So you diagnose all that by alpha-fetoprotein mom levels. Unconjugated estriol comes from adrenals. So in cases of 13, 18, 21 chromosomal abnormalities, the adrenals don't function well. Unconjugated estriol mom levels will change and give you a risk. Then the fetal lymphatic system, which drains the head and neck via the neck to the thorax, the thoracic duct, which forms, and with 13, 18, 21 abnormalities, this does not form. So lymph collects here, and that appears as nuchal translucency. So there is a difference between nuchal translucency and nuchal fold. Nuchal fold is a fat, and the fat accumulates in 21 chromosome Down syndrome here after 14 weeks. So after 14 weeks, it will be known as nuchal fold thickness. And before that, there's nuchal translucency, which is a collection of lymph. Now, because of the fact, the lymph gets compressed and it does not now look like translucent after the 14 weeks. So let's see what the test will tell us. So a screening test will provide an individual assessment of risk. The advantage is that if you do a risk calculation, you will reduce the number of diagnostic procedures, amniocentesis. When I was trained in Singapore in 1986, all pregnancies over the age of 35 underwent an amniocentesis because there were no biochemical risk calculation tests. So we were doing 100 amniocentesis and finding out only 1 Downs. So 99 amniocentesis were done useless. So you need to have a test which out of these 100 will shortlist 10 people who are at risk of Downs and then do an amniocentesis. So you get a detection rate much higher and a false positive rate much lesser. While a diagnostic test is the one which will take out the tissue and do a genetic analysis of the tissue and give you a definite diagnosis. So this could be CVS or it could be amniocentesis. So what is our prelude for our country? So you and me who are practicing obstetrics should offer screening tests universally, everyone. Now, it is not necessary that the patient will accept a screening test because of whatever reason, psychological reason, religious reason, physiological reasons, monetary reasons. So it is not a compulsory test. So you have to discuss screening if they accept or they may not accept. Then you do a prenatal screening counseling. That here is a blood test, which will give you 80 to 90%. Here is an IPC-PS, which will give you 99%. So you choose the test, and if it comes positive, you have to undergo amniocentesis, and then we do 100% diagnosis. So that pre-test counseling is very, very important, and it should be non-judgmental. You cannot say if the test comes positive, you can abort the patient. No. And then when the report comes back, you have to do a post-test counseling of the risk, benefit, and cost. And of course, in your clinic, you should have a lot of leaflets, a lot of infographics, and a lot of videos running in. And we follow the FOXY protocol of genetic screening, or the Adbhut Matata protocol, which we came forward in 2018. And this is available on the website. If it is not, you can just WhatsApp your number to me and I'll send it to you. So first, we'll divide screening into first and second trimester, which I'll just show you how. So the first trimester serum markers, which you need to do is, if you do a dual marker, PAPE and beta HCG, both come from placenta. In the first trimester, it's a placenta which is forming. So if it is abnormal, it is Down syndrome, 13 or 18, or the other problems. In the second trimester, we do a quadruple test, 4 tests. Triple test is out. Please do not advise triple test at all because the detection rate is very, very poor. So do not write. If you write triple test, people say you are not updated. But there are some markers which can be added to this. We can do the quadruple test in the first trimester also. Let's see that. So in the first trimester, you do a quadruple test, which includes PAP-A, free beta HCG, PIGF, and alpha fetoprotein. Now, a lot of genetic specialists will argue that alpha fetoprotein is not required in first trimester because it picks up open neural tube defects which develop or show up in the second trimester. And ultrasound can do a good job. Well, it can, but you get a detection rate of 80%. Only by biochemistry. Now, if you add NT to it, that means ultrasound, the detection rate goes up to 90%. This is Indian study, our own Indian study. And if you need to do a PIH screening, then you add the uterine artery pulsatility index and a mean arterial pressure, and early PIH, you can pick up as much as 100%, and late PIH detection rate of 80%. So that is the goodness of biochemical tests along with ultrasound. So what is this quadruple marker in first trimester, or what is this extended first trimester screening, EFTS? Now, there are two tests which are available in India, two packages by two companies, the Be Happy test and the pentamarker test, 5. The Be Happy test, as the letters say, blood pressure, extended clinical history, which is very, very important, HCG, alpha fetoprotein, PAP-A, PLGF, and the first trimester scan, NT. So these are all computed into it, and you get a report in 3 days, and it gives you a risk of open neural tube defects, it gives you a risk of chromosomal defects, and gives you an early risk of PIH. So it's a Be Happy test. The pentamarker, which is being offered by the other company, are similar, but they have added inhibin to it. So free beta HCG, pregnancy-associated plasma protein of PAP-A, alpha fetoprotein, PIGF, and dimeric inhibin A. So inhibin is added. And this again gives you a cutoff and a risk almost up to 90% for chromosomal anomalies and for PIH. When you compare only double marker with the pentamarker scores much better and has an additional, the expense is not that much. If the double marker is being charged at 2,000, this probably costs about 4,000 or 5,000. So it is worth doing a pentamarker for all pregnancies if they can afford, because you get a 90% detection rate with only 1.4% false positive. So how should we go about? We should screen the aneuploidies in developing countries by first taking a detailed history and maternal age. If she's over 35, she's high risk. So this is known as a priori risk before testing, risk before testing. Then you do the testing. Biochemical markers, you can do double marker, extended fetal marker, pentamarker, or Be Happy test, and the ultrasound, NT, and make a risk. Then that will modify the risk of only the age. And then, of course, we will identify which are at high risk, intermediate risk, or low risk, and we will accordingly do the next testing, which is the diagnostic test. So when can we offer screening? We can offer screening before 14 weeks, after 14 weeks. It is unfortunately the 14th week, which is a gray area, because the moms are not well defined. So you do, so your scan has to be 10 or 11 to 13 weeks, 6 days, or after 15 weeks. In the 11 to 13 weeks screening, you have an option of double marker, EFTS, quadruple screen, pentamarker screen, or Be Happy test, or a contingent screening. Screen in the first trimester, do not give a risk, take her to the second trimester. Sequential screening. In the second trimester, when the BPD is over 30, 15 weeks onwards, you do the quadruple marker only. There is no role of triple marker. I'm telling it again and again. Or, and as an alternative to all this, which will be the future, is that from 10 weeks to 17 weeks, you can do a NIPS, non-invasive prenatal screening by cell-free DNA from the maternal blood, which is very, very good test. Then in the first trimester, we also do an anomaly scan at the crown rump length of NTNB, ductus venosus, tricuspid regurgitation, and early anomalies. When we do all this, then we put them into high risk, intermediate risk, or low risk. High risk is when your risk is coming 1 in 99, chorion villus sampling. Intermediate risk when it is coming from 100 to 1000. Quadruple test in the second trimester, or a NIPS, because you have to offer another screening, and of course the 20-week ultrasound, which is known as a genetic sonogram or anomaly sonogram, which is essential for all. Low risk, you do not do any further screening test. You do only the ultrasound at 20 weeks. So based on all this, UK model was proposed, which was good for us, that in the first trimester, do a beta double marker and NT, make them high, low, and intermediate risk, and accordingly do a CVS, reassure, or further screening in the borderline risk. So that UK model. But we have made this in 1 in 99, 100 to 1000, and more than 1000. While UK said 1 in 250, less than 1 in 1000, and 251 to 1000. Now, based on the newer tests which we have, the pentamarker, the Indian whole scenario can be changed. And you do a Be Happy test, which includes ultrasound, and put them into low and high risk only, no intermediate risk. Low risk, just screen them. Low risk, again, the genetic ultrasound, again, if it picks up something, becomes high risk and amniocentesis. While all the high risk will undergo NIPS, CVS, or amniocentesis. NIPS, remember, right now is a screening test. Though we are able to do karyotype with it, once we have that total karyotyping done by NIPS, probably it will replace all the screening methods and the diagnostic test also. So that might happen. So the proposal in India is to do a contingent test that is combined extended first trimester screening, or an integrated test where you test in first trimester, test again in second, or you add the test only by NIPS and preeclampsia test, that is PIGF, PLGF, and alpha-fetoprotein for open neural tube defects. So that these are the three methods which we could follow for our country. Let's come to the second trimester. First trimester, we are now very sure that we have to do an extended fetal. Second trimester, of course, an ultrasound is very important. And if you have 3D, 4D, that's even better for all the anomaly scan. But remember, see, the triple test is in red, only 65%. So you switch over to the integrated test, that is add the first trimester to the second trimester, get a detection rate of 93%, or only a quadruple test, get a rate of 75%. And alternatively, don't do this, offer NIPS to everyone. Triple test, please give up. In this second trimester, you also have to do the genetic ultrasound or anomaly scan, and that should be done by an expert. And there is software which will calculate the risk now as 1 in 250 or low risk 251 to 1000, which you continue for antenatal care. And if it is, but remember, if your ultrasound picks up any structural defect, extra fingers, cleft palate, omphalocele, or any gastroschisis, anything, then no need to do any biochemical test. Straight away to amniocentesis if it is a non-lethal anomaly. If it is a lethal anomaly, anencephaly, terminate. Then no need for doing amniocentesis or things like that. So why is it important for us to do early testing? Because in India, the law is 20 weeks. With court permission now gone up to 24 weeks, which is a recent amendment. And remember, ladies and gentlemen, do not terminate a pregnancy on only screening test. I have seen pregnancies being terminated for NT 3.5, or a quad marker high risk, or a double marker high risk. Terminate. Please don't do that just because the patient does not have money to do a further testing. That is not ethical and not scientific and not correct. Now, when you have done a screening and now you have done a diagnostic test, amniocentesis, fluid nikal liya. Now what to do? So what to order? Abhi kya karte hain? Fluid nikal lete, POC, karyotype likh ke, we just send. So you must know why. What are you asking? First, how will you take out the tissue? You'll take out the tissue by CVS, 11 to 14 weeks, or you'll take out the amniocentesis after 14 weeks, 14 to 19 or 20. These procedures have their learning curve. Please learn it with an expert. We do a amniocentesis training program and you can learn it with us and then you do. But after that, either you will ask for a karyotype, or you will ask for a FISH, or you will ask for a PCR, or you will ask for a QF PCR, or you will ask for array CGS or array-based comparative genomic hybridization, or you'll ask for CMA, or where you will ask for NGS or next gene sequencing, or whether you ask for exome. So you have to find a solution to the problem by asking for any one of these tests. So you have to know what are these tests and what do they tell us. So that is a different lecture, but better study that. So ladies and gentlemen, let me conclude. We can do the prenatal testing by a fully integrated test. One option, first trimester NT and PAPA, not beta HCG again here. No risk is estimated. Second trimester, do beta HCG, alpha fetoprotein, estriol and inhibin, quadruple test, then make a risk and into high or low risk. This is integrated testing, but you have to test twice. Then we do stepwise. Stepwise, do a double marker and NT in the first trimester and do a risk estimation, high risk, and then high risk are done by you take them to CVS or NIPT. Low risk, you do a second trimester screen again or an ultrasound and then go and calculate the total risk. And the third, which we all should be aiming at, is a contingent screening, where in the first trimester, we make 3 types of risk: low, high, and intermediate. Low, do routine antenatal screening and only ultrasound at 20 weeks. Intermediate, can offer them second trimester screening or borderline risk. High risk, do an invasive test and come to a diagnosis. So the take-home message, ladies and gentlemen, is first trimester screening 11 to 13 weeks after discussing and accepting or not combined tests, FTS, extended FTS, or straightaway NIPS. Second trimester quadruple or NIPS. Divide them into low, high, and intermediate risk. Low risk, only ultrasound required, or maybe alpha fetoprotein. High risk, invasive test required. Ask for karyotype, QF, PCR, FISH, or CMA, or NGS, or whole genome sequencing, single gene sequencing, depending on what the patient has, the problem. So you need to know how to do a pedigree charting and how to do the history. And intermediate risk, offer them NIPS or take them or only the ultrasound. And you have to tell them that it's limited. The efficiency is 93 to 99%. And a pre and post test counseling is very important. So look at this last slide. When we do problems of genetic test problems, you have 5% environmental, 25% chromosomal, 20% single gene, 50% complex. So when you do an NIPT, you pick up about 75% of all chromosomal defects, not 100%. When you do CVS or amniocentesis, you pick up 100% chromosomal defect and 50% single gene defect. But when you do ultrasound, ultrasound is a very, very good marker screening test for all environmental structural defects, chromosomal structural defects, single gene structural defect, or complex anomalies. So ultrasound is of more value than molecular genetic testing. So in India, we should be good with ultrasound and do an ultrasound first and then take them for the further tests. Thank you very much for inviting me here. We have all this in the Adbhut Matra protocol, and we have all this for you in the iMums app, which you can give to your patients, and the patients can directly access information about pregnancy care with the iMums app. All of you, about 1,000 doctors are associated with the iMums app, and 1 lakh pregnant women are using it right now. So if your pregnant woman is not using this app, tell them to use it. Thank you very much for inviting me here to express my views about prenatal testing, prenatal screening in pregnancy. Thank you.